Medicare begins with a Medicare card. You've got to have a card to be able to use your Medicare benefits. Now, I know most of you have seen Medicare cards before as you worked with your parents. Medicare claim numbers were always someone's Social Security number, but today it's not like that. When we get a card, we're going to have a Medicare claim number, but it will be 11 digits that are some letters and some numbers that are just totally random. And so Medicare cards today look like this. The effective date on the Medicare card is always the first day of the month that you begin your coverage. Now, this card represents what we call original Medicare, which is broken up into two parts, Part A and Part B. A is called hospital and B is called medical. A is pretty much everything that's going to be inpatient services. B, pretty much everything that's outpatient services. And so our first question is this: how do we get a Medicare card? In other words, who is eligible for Medicare benefits? Well, anyone 65 who has paid Medicare taxes for at least 40 quarters or whose spouse has done so is able to draw Medicare benefits. Now, if you're working for someone right now, 1.45% of every dollar that you're making is going into Medicare. Your employer matches that. 6.20% is going into Social Security, and your employer matches that. We call these FICA taxes. If you're self-employed, of course, you pay the full amount. But the point is, we're all funding Medicare and Social Security. And as long as we've paid into that system for at least 40 quarters, which is basically 10 years worth of work, we're able to draw benefits from those systems. Now, there are times when people do not have 40 quarters. My wife is a perfect example of this. We've been married 32 years. We have 7 children, 5 that were born into our family, 2 that we adopted from the country of Uganda. My wife for 30 years has been a homeschooling mom, has done a great job at it. I always tell her you work very hard, but she does not make any income for being a homeschooling mom. And so does she have to worry though about Medicare or Social Security? And the answer is no, she doesn't, because she can draw those benefits off of my work record. And that's what we're talking about, a qualifying spouse. So we're always looking for 40 quarters. Either it's 40 quarters of your own, or it could be 40 quarters of your present spouse or a previous spouse. There's some very specific rules about qualifying spouses, but it is possible to draw those benefits off someone else's work record. Now, the second way you'll see that people qualify for Medicare are those that are under the age of 65 who have been receiving disability benefits either from Social Security or from the Railroad Retirement Board. So what happens, they've been diagnosed with maybe a physical or maybe even an emotional or mental disability, and they're receiving those benefits for 24 months. And on the 25th month, they're automatically going to be enrolled into Medicare. Of course, to be a recipient of Medicare benefits, you do have to be a U.S. citizen or a permanent legal resident. So that's who's eligible for Medicare. Now, the second question is who needs to enroll into Medicare? Well, for some of you, you're going to be automatically enrolled. There's nothing you have to do at all. And so here's the way this works. Those turning 65 who are already noticed receiving a Social Security check or a Railroad Retirement Board check, you will be automatically enrolled into Medicare. Medicare understands that you're turning 65. They know you're receiving retirement benefits, so that's why they automatically enroll you into Medicare. And so in this scenario, what happens is your Medicare coverage begins the very first day of the month that you turn 65. So it's your birth month when you turn 65 that you're first eligible for Medicare. Now, there is one exception to this, and that's that if you're born on the first day of the month. So let's say I'm born April 1. My Medicare coverage will begin in March. They always move you back 1 month. If I'm born December 1, I will be eligible for Medicare then in November. So if you're born on the 1st, we move it back a month. But if I'm born on the 2nd day thereafter, it's always my birth month when I turn 65 that my Medicare benefits can begin. And in this scenario, when you're automatically enrolled, the Medicare card is going to show up 100 days prior to your birth month. Now listen, not everyone is on Social Security, so therefore not everyone's going to be enrolled into Medicare. So this applies only to those that are already receiving a Social Security check or benefits from the Railroad Retirement Board. That's the group of people that will be automatically enrolled into Medicare. Now, some of you then are going to get a Medicare card, and what does happen is there's sometimes people get the Medicare card because they're on Social Security, but they really don't want to start Medicare, at least not yet. And so Medicare knows this is going to happen, and so they make provision for you to be able to amend some of your Medicare benefits. So the question is, why would someone not start Medicare when they're first eligible to do so? Well, the answer to that is because they or their spouse have an employer-provided plan that they really like. They like the cost of the plan, the coverage of the plan, but the Medicare card has shown up. So what do you do to amend your benefits? Well, you saw the front side of the card. This is what it looks like on the back side. And this is your opportunity to amend part of your Medicare benefits. Now, you got to remember, if you're on Social Security, you have to stay enrolled in Medicare Part A. But you don't have to take Medicare B if we have some kind of a group plan that's available, either that of yours or your spouse's. So if you want to stay on the group plan instead of going on Medicare, you can amend your benefits by doing this. You would check the box and you will sign your name. And notice what it says. It says, I do not want medical insurance. Remember, Part A was called hospital, Part B was called medical. And so what you're saying, I don't want Part B. We have to stay enrolled in A, but we don't have to take B if you're working, your spouse is working, covered by a group plan. And so what you would do is you'd send the card back in to Medicare. And when they get the card, they will amend the benefits. They'll drop off B. And again, you can pick that up at a later date. They'll send you back a new card that'll say Part A, hospital only. Now listen, if you or your spouse are not working, you're not doing this, because everyone has to start Medicare at 65 unless they or their spouse are working. So again, if you have a group plan available, you can have your benefits amended. But if you're not, you're going to keep the card. So if we keep the card, what's going to happen? We're going to start paying for that Part B insurance. In 2021, that is $148.50 a month. It's going to come right out of your Social Security check. If you go on Medicare and you're not on Social Security, you, of course, will pay for that quarterly. But if you send the card back in, they will drop off the B, and there'll be no cost for Medicare Part A for most people. All right, so that's the way you can amend your benefits. Now, let's talk about those of you that are going to need to self-enroll. And this would be people who are turning 65, but you're not yet receiving Social Security or Railroad Retirement Board benefits. You do not have a group plan available. You or your spouse are no longer working. You're going to start Medicare at 65, so you're going to need to self-enroll. Now, here's the process of self-enrolling. Before enrolling today into Medicare, you must create what is called an SSA.gov account. Now, SSA.gov accounts have been around for years. They were advertised a lot, but they were totally voluntary. Today, if you're going to do anything online with Social Security or Medicare, you have to establish an SSA.gov account. And there's a process you follow. We actually have some training on this that I'll not include in this particular series, but there will be some training available for SSA.gov accounts, but you do have to establish one. And if you have any kind of struggles with establishing an SSA.gov account, you can call your local Social Security office and they will walk you through the process. But if you're going to do it online, you're going to have an SSA.gov account. Now, once we have that account, now we can enroll online into Medicare, and you would go to ssa.gov/Medicare only application. And this will take you about 7 minutes to enroll into Medicare. It's a very user-friendly site. You'll be able to do this really on your own. It's really quite simple to do. Now, if you don't want to do it on your own and you would like to make an appointment with the Social Security office, you can do so. So to make an appointment with your local Social Security office, you would go to ssa.gov/locator, and they will ask for your zip code, and it will populate then what is your local office that they'd like you to work through. There will be a phone number on there where you can call and set up an appointment. I will tell you this, sometimes it takes 2 or 3 months to actually get an appointment like that. But again, they'll help you through that whole process if that's the way that you decide you want to go. Now, this process, you'll notice once we go through all these steps, once you've enrolled, your Medicare card is going to arrive in approximately 4 weeks. All right, so start to finish, it's about a month. Now, I want you to understand something. If you decide to work with us as a company, we will help you with all of this, help you create the SSA.gov account, we'll help you do the Medicare application as well. And so all this can be done by us if you choose to work with us one day. But the point is, this is exactly the process that you who have to self-enroll are going to need to follow to get that Medicare card. All right, now I want to talk about one of the more confusing parts of Medicare, and that has to do with enrollment periods. And so to really understand enrollment periods, you have to ask yourself, well, what am I enrolling into? And so there's basically just 2 broad categories of enrollments. One category is getting into the Medicare system to get that Medicare A and B card. And we actually have 3 opportunities to be able to get into Medicare. So I'm going to explain those. Now, I'm really a proponent of people having insurance beyond just A and B. I think to have Medicare A and B is really very risky today. And so once we've been enrolled in A and B, then we'll probably want to get other insurance. Those are called supplemental plans or advantage plans and prescription drug plans. So what we have are enrollment periods to get those other insurance products. Okay, now what makes it confusing is both of these, they're really different, but they use some of the same terminology. There's lots of overlap. So again, when you're dealing with or reading about enrollment periods, you have to say, what am I doing? Are you enrolling into Medicare to get the Medicare A and B card, or are you getting other insurance products? All right, so I'm going to deal with other insurance products here in a few minutes, but I want to still deal with this getting the Medicare card and the enrollment opportunities to do that. There's actually 3 of them. Getting that Medicare card, they're all given an acronym, and they just simply mean the initial enrollment period, the special, or the general enrollment period. Now, 2 of these 3 are wonderful, and the third one's terrible. I don't want you to use it. So these are the 2 that I'm going to focus on during this session today, because everyone watching this should be using either the IEP or the SEP. The general enrollment period means someone's made a mistake, and there's penalties when you have to use that one. I'll kind of tell you a little bit about that, but I want to focus on 1 and 2. So let's look first at this initial enrollment period. So this initial enrollment period is very specific. It is 7 months for you to sign up when you're going to start Medicare at 65. Now, again, not everyone's going to start at 65, but those of you that are going to start at 65, this is when you must enroll. And so those 7 months are very specific for your birth month. They're 3 months before you turn 65, the month you turn 65, and then 3 months after you turn 65. And if we have to start at 65, folks, we have these 7 months to do it, and only these 7 months, because if you don't do it now during these 7 months, you've made a mistake, all righty? And so what we want to make sure you understand that if you have to start right at 65, when that coverage should begin, you should enroll in advance, which means what? These 3 months before your 65th birth month. They'll start taking that application right at 90 days prior, so that then your coverage will begin the very first day of the month you turn 65, when you're first eligible to do so. So this is the initial enrollment period for those starting at 65. Now, let's give this visual example of someone whose birthday is in January. They're going to turn 65. So remember, 3 months before, month of, 3 months after. And the month that we choose to enroll will be the month that Medicare is going to start our coverage. So the month we enroll, then that determines what month our coverage will begin. And so let me give the example. Someone in turning 65 in January, 3 months before, anytime they do that enrollment, notice when their coverage begins, January 1st. So any of those 3 months will get us started on our birth month. But if for whatever reason, could be confusion, procrastination, or whatever reason, someone who is turning 65 enrolls into Medicare during the month of January, their coverage won't start until February. So what's happening is your coverage is actually getting delayed 1 month. But watch what happens after that. If my birthday's in January and I enroll in February, now they skip 2 months, and now my coverage is delayed until April. If you enrolled in March with a birthday in January, they skip April, they skip May, and your coverage begins in June. If it's an April enrollment, they're going to skip May, June, and my coverage starts in July. So what's happening? They're delaying my coverage. And so if I wait 1 month, they put me off 2. I wait 2, they put me off 3. And if I wait 3, they put me off 3 more months. So it's very critical that you choose the right month to do the enrollment. Every week, I'll have 2 or 3 cases of people that'll call us, and they have actually messed up their Medicare enrollment. In fact, I've had people have multiple thousands of dollars of penalties because they did not enroll in Medicare at the proper time. And that's what we're saying. It's very critical that you select the right enrollment period. So that's the initial enrollment period for those starting at 65. Now, the second enrollment period, that's a good one, is called the special enrollment period. Now, this period is for those who didn't start Medicare at 65. Why? They didn't need to, because they were already covered by some kind of an employer-provided plan, either theirs or their spouse's, and they like that plan. They like the cost of the plan and the coverage of the plan. But now they're ready to retire, and it's time to go on Medicare. And so this particular period is different in name, of course, but also in the process. And so what's required to enroll in Medicare during the special enrollment period is this. We have to prove to Medicare through the Social Security office and certain paperwork that you have had credible insurance through an employer plan all the way back to 65. Quick example. The most elderly people I've ever put in Medicare to date were a 79-year-old lady and her husband, who was 83. They had never used their Medicare benefits at all, so we're going to put them in Medicare. She's 79, he's 83. How do we do that? Well, we have to have a verification that they've been employed and insured all the way back to 65. So for her, we had to go back 14 years. For him, we had to go back 18 years. And the form that we use is called an L564, CMS L564. Now, I know you can't see this probably, but I just want to show you that it is a one-page document. And in this document, we will put in the employer's name and their address, and your name and your address, and your Social Security number. And this form, we'd have to have one for each spouse. And this will go to the HR department. And the HR department is going to verify that you've been working and that you've been insured. And again, we got to go all the way back to 65. And so if you make a job transition, let's say at 67, and you get a new job and then you retire at 72. So if we have 2 employers since 65, each of those employers has to fill this document out. And so we have to have every single month accounted for. So remember this, if you work past 65 and then you change jobs and you're in transition, do not go without insurance for even one single month, because we have to document every month. So if looks like you're going to be without insurance for maybe a month or 2, then I would suggest you go on Medicare. you can do that. Go on Medicare for a month or two, and then we can come out of Medicare and opt out of it, and then you can go on the group plan. But every month has to be accounted for, and the L564 form is going to do that. Now, we have a second form called the CMS 40B. And again, it's a separate form. I just laminated the two together for our session today. But this document is very simple to fill out: your name, your address, social security number, date of birth. And then at the very bottom is the most important part of this document, because what you're going to do here is you're going to pick the month you want to start your coverage. And so if my group plan is going to end December 31, I'm going to retire then, I'm going to go on Medicare January 1, I'll tell them, please begin my Medicare January 1, 2021, or January 1, 2022. Whenever you're going to start that, you just pick the month. And again, we'll fill this document out about 60 to 90 days prior to your retirement. And so we have the L564 from the employer, and you fill out the CMS 40B. And again, if you work with us, we'll do all of this for you, guide you through this whole process. But these two documents are necessary on the special enrollment period. Now listen, these were not required during the initial enrollment period, the one that revolved around our 65th birth month. In fact, all we have to have is 40 quarters, and we can do all of that online. But this process will be required if we're coming in after 65 and 4 months old and beyond. All right, so here's the rules for using the special enrollment period. It says you can use the SEP, this period, and this process to sign up and start Medicare coverage anytime. Notice that you're still working, right? So what does this mean? This means that if you're Medicare eligible, if you continue to work past 65, usually every year your employer goes through this enrollment period at work, and they usually pick an insurance company and then give you a few options for you to select. Remember that if you're working and you're over 65 and you're eligible for Medicare, you don't have to take the group plan. There are a lot of people today that are opting to go on Medicare while they're still working. Well, why would they do that? Because sometimes that makes financial sense. And again, we're happy to evaluate this with you to compare that. But for us to help you, what I have to know about your situation, as far as would this be a good move or not to go on Medicare while you're still working, I want to know about the premium you pay for the plan at work. What's the deductible? Do you meet it? What's the co-insurance on the plan? And what's the max out of pocket for the year? And what are your medications? And so with that information, we can help you evaluate if Medicare really would make sense. Now, sometimes it doesn't make sense. I can tell if you're on a lot of expensive medications, I'd probably say stay right where you are, because those medications at your work plan probably going to be a little cheaper than would be on Medicare. Maybe, usually that's the case. So expensive medications could help determine that decision. Or if you have a younger spouse that has no other insurance options, if you go on Medicare, that's going to adversely affect your spouse. So we would say stay right where you are. Or children are covered at the age of 26. If they're on the group plan, we'd say stay right where you are. But if no one's going to be hurt financially by you going to Medicare, sometimes that does make sense. All right, and so we're happy to help you evaluate that decision. But we would always tell you our opinion and why we would encourage you to do one or the other. Now, if you do have a spouse that's also eligible for Medicare, we like to know two things about your premium. I want to know the employee-only price and the employee plus spouse price. We have this happen all the time. In fact, just my most recent case, we had a lady who was working, husband retired, but covered by her insurance. The employee-only price on the plan was $100 a month. We had the spouse to the plan, it moved to $500 a month. So it's costing her $400 a month to cover her husband. So my advice to them, and they followed it, I said for the wife, I'd stay right on the group plan. That's a good value, $100 a month, but too much for the husband for $400. So we put him on Medicare, and they saved some money and actually had better insurance for him. All right. And so those are the things that we would need to know. And that's what this statement means. It means you can sign up, start Medicare coverage while you're still working. And if that makes financial sense, then you may want to do that. Another thing in which this means, most people, as they approach retirement, are going to set their retirement date. And so while you're still working and you know that you have to go through this process, we encourage you to do this about 60 to 90 days in advance. People ask me all the time, Marvin, when do we call you? 60 to 90 days before you retire, it's time to start doing this process and looking at all the plans and really making all those decisions so that when the group plan is over, December 31, you're ready to start Medicare and all the other insurance options start January 1st. All right, so that's what we mean by that particular process. So some of you are going to use the special enrollment period and the paperwork that's a part of that. So let's do just a quick recap as we talk about enrollment periods. There were 3 of them. If we're going to start at 65, which means what? We're not covered by an employer plan any longer, or a spouse does not have that, so we have to start at 65. We're going to use the initial enrollment period. For those of you that are on Social Security and the Medicare card showed up in the mail, That's the enrollment period they use for you. For those of you that are not on Social Security but have to start at 65, we're going to do all this on our own during the initial enrollment period. For those of you that are going to keep working past 65 and you're going to retire at a later date, you're at least 65 and 4 months beyond, could be 67 or 69 or 79, 83, 102, doesn't matter. Anytime we come in after 65 and 4 months old, we have to use the special enrollment period. And if we're using this one, remember, you were working at 65 or your spouse was, because that's the only way you can do this one. And then lastly, we have the one that's the bad one, the terrible one I don't want anyone to have to use. It is available. And this is for those who made a mistake, which means what? They didn't take one or either one of these, and so they missed out their opportunity to enroll during the right period. And so now they have to come in during the general enrollment period. But this one has three problems to it. Number one, you can only enroll during the months of January, February, or March. That's it. You can't come in April to the rest of the year. It's not possible. So when we make a mistake, we can only enroll first quarter. But notice when the coverage begins. It begins the beginning of the third quarter. So I enrolled the first quarter, but coverage doesn't begin until July 1. And then there will be lifetime of penalties that we will pay for our Medicare B as well as for our drug plans. And so that's why I'm saying we don't want anyone to use that. It is available. As long as we have 40 quarters, we can always come in later, but we'll suffer the consequences of having come in late. All right, so we want to use one or number two. Now, I'm going to focus on the benefits of staying in original Medicare A and B. What does that A and B look like? First off, A is called hospitalization. And for the majority of people, actually 99%, most of you are not going to pay a premium. Why is that? Well, because we've been paying money into Medicare all of our life, through our payroll taxes. And so as we pay that money in, Medicare says you paid in a long time, so we're not going to charge you any premium for your Part A. And that's why it's free for most people. Now, when we use Part A, it's what we would call an open access system, which means you do not have to worry about any kind of networks. So in Medicare, there are some plans that have networks, but those are called Advantage plans. I'll discuss those here in a few minutes. But with Advantage plans, we have networks, but in original Medicare, we have no networks, which means you can go to any hospital, any skilled nursing facility. That takes Medicare. That's the only requirement. So really, Medicare is your network, and that's it. So what's covered under A? Well, all of our inpatient hospital care, you've been admitted to the hospital. So your nursing services, the room and board, and the test, and those things that the hospital is running for you. A system is going to pay the bills. Home health care. This would be someone that was in the hospital and needed some rehab, not the intensity of like a skilled nursing facility. So they send them home, and those home health care follow-up visits are going to be paid through Medicare A because it started in the A system. So wherever it starts, as far as the original bills, that's where home health care continues to pay. Now, skilled nursing is for someone that was in the hospital and needed fairly intensive rehab. This would be typically after a stroke, maybe a hip replacement or some kind of a fall or an injury, and they have to go to a skilled nursing facility. And so it is the A of Medicare that's going to pay for those. And then lastly, hospice. Now, for years, if someone was on hospice, they were terminal. In fact, we had written documentation where a doctor said this person has probably 6 months or less to live, and then they would receive hospice benefits. Now, those days are over. There are a lot of people today on hospice that are not terminal. So whether it's because we're terminal or some other health issue, we're receiving hospice benefits, it's the A of Medicare that's going to cover those expenses. All right, so those are the major items covered by Medicare A. Now let's talk about what it looks like financially. Now these numbers are all for 2021 season. The 2021 Medicare A deductible is $1,484. Now remember, a deductible means you pay this first and then Medicare pays after that. And you'll notice this deductible is your full out-of-pocket for notice up to a 60-day stay. And what that simply means is whether you're in 1 day or 2 days or 10 or 60, anything between 1 to 60 is the same cost to you, $1,484 out of your pocket, and then Medicare is going to pay the rest. And in case you don't know, that really is a bargain. Now, this deductible is unique because it's tied to what we call a benefit period. You and I in our group plans and individual plans are accustomed to annual deductibles. This is a benefit period, which means the benefit period defined by Medicare says this: you are admitted to the hospital, my benefit period begins. And let's say I'm in the hospital 7 days. From the date of discharge, 7 days after being admitted, when I'm discharged, my benefit period now will go for a full another 60 days. So anytime from discharge for the next 60 days, if I have to go back to the hospital, I'm rehospitalized, I am in the same benefit period under the same deductible. But let's suppose that I get pneumonia in February and I'm hospitalized for it, and I go home 7 days later. I'm discharged, finally heal up from my pneumonia, I go home, and nothing happens, but let's suppose you're in a climate where there's ice and you are on some ice in December and you trip and you fall and you break your leg. So I had pneumonia in February and I broke my leg and had to be hospitalized for and operated on in December. In that year, I would have paid 2 different deductibles. So it's not annual, it truly is tied to this benefit period. So anytime if I'm out of the hospital more than 60 days, that deductible can occur again. All right, so that's the way that works. Now, if we're ever in the hospital, notice longer than 60 continuous days, what's going to happen is Medicare covers us for 3 more months. But notice month 3 carries a $371 a day copay. Month 4 and month 5 carry a $742 a day copay. Now, it is true that these do not happen often, but they do happen. And these are for folks that we would call these extended stays. Normally, people are, of course, very, very sick, sometimes even in a coma in these situations. But these would be your responsibility, the daily copays. And when you do the math on this, what you're going to notice is that month 3, if you're in that full month, is going to cost you about $11,000 plus out of your pocket. And then month 4 and month 5, that's going to cost you about $22,000 every month out of your pocket for month 4 plus month 5. All right, so these extended stays are very, very costly. They are rare, but this is how they're billed when they occur. All right, now let's talk about skilled nursing facility. Again, as we talked about, this is something that is more intensive rehab. Someone's had a stroke, a hip replacement, fall, or injury. And so the rules are this. Medicare says that they will cover everything, the cost of a skilled nursing stay, all those costs for the first 20 days. There's nothing out of your pocket. But they do attach one very important, yes, really critical rule to this. For them to pay everything, you've got to be in the hospital a minimum of 72 hours. 72 hours, so 3 full days, and then the doctor can put you in skilled nursing. And as long as we had that 72-hour stay in the hospital, Medicare will pay all the bills. If I'm not in 72 hours, Medicare will pay nothing at skilled nursing, and that's why they always keep someone 3 full days or longer. All right, now, if I happen to be in longer than 20 days, notice I have 80 more days of eligible coverage by Medicare, but now I have a responsibility of a daily copay, $185.50. They tell me right now that the average Medicare recipient is in skilled nursing about 30 to 35 days. So you're spending probably $2,000 to maybe $2,500 on average out of your pocket. All right. So those are the things that you're going to be responsible for when it comes to Medicare Part A. Now let's talk about Medicare Part B. Now Part B is called medical. This is the outpatient side of Medicare, and there is a premium for that. It's not free. The majority of people, actually 93% of the population, will pay $148.50 for their Part B premium in 2021. Okay, that's 93% of you. If you're on Social Security, this money is going to come out of your Social Security check every month. If you're not, if you're delaying Social Security, what's going to happen is they're going to bill you for this quarterly. So that would be times 3. So basically $450 every quarter that you'll be billed. Now notice I said 93% will pay this. You'll see a plus sign here, right? Well, there's 7% of the population that will pay more. Now, I don't have during this session the time to go into this, but we do have further training on this. But those of you that are high income, and high income means this, single filer, $87,000 or more, you're going to pay more for your Part B. Couples who file a joint return, $174,000 or more, you're going to pay more for your Part B premium. Those additional amounts are called IRMAs. It's an acronym, IRMA, Income Related Monthly Adjusted Amount. Okay, so some of you are going to pay more. And again, I have more training on this, but for today's session, that's all I'm going to say. I just want to make sure you understand high income people will pay more for their Part B premiums. All right, so that's the way that works. Let's talk about getting this B coverage. Again, it's a no network system. Remember, only Advantage plans have networks, and Original Medicare does not. So you can go to any doctor, any specialist, any provider that's going to take Medicare. You can go there if you stay in Original Medicare. What's covered? Everything that would be outpatient type services. So labs, cataract surgery, MRIs, anything that you do on an outpatient basis, it is the B of Medicare that's going to start paying on those bills. All the doctors, all the specialists that you would go to see in their office, or notice they come to see you in the hospital. You see, folks, B always pays the doctors. A paid the facility, but B is going to pay the docs that take care of you. So this would include the ER docs, the hospitalist that makes the round to check on you while you're hospitalized. This would be surgeons, anesthesiologists, all the docs that take care of you are going to be paid through the B of Medicare. Now, DME stands for durable medical equipment. This would be equipment that's reusable. It's used for services such as diabetic supplies. This would be CPAP machines. If you have sleep apnea, you probably have one of those machines. Folks that have a scooter or maybe a wheelchair or a walker, a bed in the home, that's all durable medical equipment, things that are medically necessary to take care of you that can be reused. And so it is the B of Medicare that's going to cover those expenses. Now, if you happen to be an insulin-dependent diabetic, your insulin pump is considered durable medical equipment. And the good news for you is because you have a pump, the insulin going through the pump is also paid through Medicare Part B. And so that's good. I wish all insulin was paid through B. It's not. Most of it's paid through drug plans. But with the external pump, the insulin is going to be paid through B. Some of you ladies may have bone density issues. I hope you don't, but if you do, you know that the diagnosis typically is osteopenia or osteoporosis. And it is very common with treatment for that would be Prolia. Prolia is a very expensive shot. The good news is you don't self-administer Prolia. You have to go to an outpatient clinic or a doc's office to get that. And because it's on an outpatient basis, the B of Medicare is going to pay for that. Prolia otherwise would be $1,500 to $1,800 copay, but we've covered through Part B, so it's much more advantageous for B to pay for that than for you to have to run it through a prescription drug plan. All right, and then lastly, preventive services. Now we're all familiar with preventive services today. When the Affordable Care Act became law back in 2010, insurance companies had to pay for certain services that are covered, considered to be preventive. And ladies have a list of things they're covered for, and men have a list. And sometimes our health history will add to our list. If we have cancer or other issues, we may qualify for more preventive services. But those items that are going to be covered by Medicare, preventive, are going to be paid through the B of Medicare. All right, so those are the main services covered through Part B. Now let's talk about it financially. Here's what we have. We have a B deductible of $203 for 2021. Now notice this is a calendar year deductible. It's not like that Medicare A deductible. That A deductible could occur more than once in a year. This is just one calendar year. So if I start in March, this is my deductible from March to December, because every year this number resets, okay? And sometimes when it resets, it stays the same. Sometimes it resets a little higher. In 2020, this read 198. So it went up $5 in that 1 year. So it went up $5. So you'd be responsible for this calendar year deductible when it resets every January. And so once that deductible is satisfied, Medicare then is a very traditional 80-20 plan. Medicare pays 80% and you pay 20%. Now the whole Medicare system is called fee for service. And that means there's thousands of services covered by Medicare, and all of those have a predetermined fee that Medicare says, this is what that service is worth. This is what that provider is going to be paid. And so of that service amount, that fee for service, Medicare pays 80 and you pay 20%. And we tell our clients this all the time. When you're on Medicare, you ask two questions. Number one, ask the provider, do you take Medicare? Most do, but ask. And then number two, if that provider is suggesting that you have a test or a lab or an x-ray or a procedure, you need to ask the provider, now is Medicare going to cover this and pay for this? And so if we're seeing a Medicare provider, and yes, this is covered, that's when Medicare pays 80% of the fee for service. You're responsible for 20%. Now we call your percentage, it's called co-insurance. It's a percentage of that bill or that fee for service. Now here's the problem with your 20%. It is totally unlimited, meaning sky's the limit. So your 20%, unless you have insurance, will never, ever, ever stop. What's the problem with that? Well, the problem with that is this is where all the doctors are paid. So if you have some serious health issues at any time, and maybe you have a couple surgeries, there's a lot going on, a couple surgeons and anesthesiologists and all those doctors that you have to see prior to surgery and after surgery, you're going to have to pay those docs 20%, and it never, ever stops. So truly, sky's the limit. This is why I'm not a real fan of A and B only. I think we need some other insurance so we can stop that, because there's a tremendous amount of risk with that unlimited amount. And then lastly, this is a surprise to a lot of people, it says you pay all physician excess charges. What is this? It means that there are some doctors that look at that fee for service schedule where the amount that they're going to be paid is specified, and they say that's not enough. We're going to add to the bill. And when they add to the bill, that is called an excess charge. So here's the way it works. We have two types of doctors that see Medicare patients. One are called the doctor that takes assignment, and then there's one that charges excess. And so the doctor that takes assignment is a physician that takes Medicare approved amounts, and they will take that Medicare approved amount as a payment in full. They don't add to the bill. So this would be a surgeon approved for $10,000 for a surgery, 80-20, Medicare pays $8,000, and you're going to pay $2,000. But if you happen to go Mayo Clinic or some other places where they charge excess, and it does happen, then they're going to add 15% to the bill. They can add no more than that. That's the limit. And when they do that, in this example, that surgeon is going to bill not $10,000, but $11,500. But notice what happens. Medicare pays the same. Medicare will never pay more than that original fee for service amount. So they're going to pay 80% of that amount. What happens is you're going to pay more. You paid the $2,000, but you also paid that extra $1,500. And again, you may have the wherewithal to write that check, but you're probably going to be disappointed you're going to have to do that, maybe frustrated you have to do that. And so here's what we know. We know that 1 out of 10 doctors will do this, 9 out of 10 will do this. So it is rare that we see excess charges, but it does happen. Now, again, that's today. I have no idea what Medicare is going to look like in 5 or 10 or 15, 20, 25 years. And many of you are going to be on Medicare 20, 30 years. And so those that are concerned about the possibility of an excess charge or going to a Mayo Clinic or some specialty place where they always charge this, many today are getting insurance to cover excess. And so what we need to realize is there are actually 2 supplemental plans. I'll show those here in just a minute that will actually cover excess charges. So they'll always cover that 15% if and when it occurs. There are other 8 plans that are available to you that will never, ever cover excess. So if you're on one of those 8 plans, you would always be responsible for the excess charges. All right, so that's the way doctors are able to bill Medicare. Now, just a couple quick statements that I want to clear up some confusion about Medicare A and B. Here they are. When turning 65, if you or your spouse are still employed, one of you or both of you still working, and you're covered by an employer-provided plan that you like, and you're not going to take Medicare, you're going to stay on the group plan, enrollment into Part A is, notice this, folks, not required. You're not required to take Medicare Part A. In fact, to enroll into Part A may not even be in your best interest. Now, the problem with this is that most of you have heard just the opposite. You've heard that even if you're going to keep working, you have to take Medicare at 65 or you're going to be penalized. And the truth is that that's not accurate. Okay, it's been misinformation that's been repeated truly millions of times, and now everyone thinks it's true, but it's not true. You're not required to take Medicare A or B if you're going to continue working. And I mention it for this reason. To enroll in Medicare A may not be in your best interest, especially if you're covered by a group plan that has attached to it what is called a health savings account. These are tax advantage accounts where you can pre-tax money put into account and use it for present or future medical expenses. It's like a healthcare IRA. And so health savings accounts are very attractive, but here's the rules. If you enroll in A while you're still working and you take Medicare A, you have to stop your contributions to your HSA. So you just hurt yourself. You lost a great tax advantage by enrolling into A. So you don't have to take A if you're still working, and certainly if you have an HSA, a health savings account, I would not do that. Now, this rule does not apply to flexible spending accounts or health reimbursement arrangements. Only HSAs. You must stop contributions if you take any form of Medicare. All right? So it's not required, even though you've heard it. It's not true. Here's the truth about Medicare A. If Medicare A is free due to 40 Social Security quarters, that's why you get it for free. Notice a late enrollment penalty is never, ever, ever assessed. So if A is free, it's always free. Only those who have to actually buy Part A, in other words, they didn't have 40 Social Security quarters, didn't have a previous spouse or present spouse they can draw those from, so they don't have 40 quarters. If they don't take Medicare A when they're first eligible, either at 65 or retirement, that is the group of people that are assessed penalties. Okay, so 99% of you, A is free, it's always free no matter when you take it. So it's just that 1% of the Medicare population that has to buy A. Those are the folks that could be assessed penalties if they do not take it at the proper time. All right, now Part B of Medicare, at 65 or older, if you or your spouse still working, covered by an employer-provided plan, notice it may be in your best interest to delay taking Part B. They don't make you take A, they don't make you take Part B if you have a group plan that you like. And you can continue to delay taking Medicare until that coverage ends. Now, I said earlier, there's some of you, you may want to work and be on Medicare if that makes financial sense. But the rest of you feel comfortable and feel confident knowing that you don't have to do anything with Medicare if you have a group plan of you or your spouses until you retire. All right, so that's the way it works. Now, A and B of original Medicare, notice, can be enhanced or can be improved by purchasing separate Medigap policies. These are called supplemental plans or Medigaps. And these are made available by private health insurance companies. Now, in part, this is what's filling up your mailbox every week. These companies send you all these packets, hoping you'll fill it out and get a supplemental plan with them. But the question is this: why would we need to enhance original Medicare? Why would we need to improve it? And why would we pay for a supplemental plan to do that? So let's review that. And here's why people buy supplemental plans, and I'll tell you the different options. Number one, because we have certain liabilities, certain out-of-pocket expenses. So let's go through those together. We call these gaps in your coverage. So on the Medicare A side, I've told you that you have a Medicare A deductible. It's $1,400, And that is your out-of-pocket cost for up to a 60-day stay in the hospital, which is going to be 99% of every situation. It's going to cost you $1,484 to go to the hospital in the year 2021, right? Now, that covers me for the first 60 days, but if I happen to be in an extended stay, that third month, which would be days 61 to 90, costs me out of pocket a $371 a day copay every day, $371. If I'm in months 4 and month 5, we had a daily copay of $742 out of our pocket. Remember, month 3 was $11,000, month 4 and month 5 about $22,000. Those are extended stays; they are rare, but when they happen, it's your liability, your exposure. And then lastly, we talked about on the A side of Medicare, if we go to a skilled nursing facility, we said that the first 20 days is paid by Medicare as long as it was preceded by a 72-hour stay in the hospital or longer, right? Medicare pays everything the first 20. After that, we have 80 more days of eligible coverage, but we're liable for a daily copay of $185.50. And that's what our liability is for the next 80 days. So that's our exposure, our financial liabilities on A. We had our deductible at $1,484. We had copays for extended hospital stays, and we had copays for extended skilled nursing stays. Now let's talk about Medicare Part B. Part B next year in 2021 has a deductible of that B deductible is $203. So 2021 B deductible, $203. After we have satisfied that small deductible, now Medicare is going to be an 80-20 plan. Medicare pays 80%, you pay 20%. What's the problem with your 20%? It's unlimited. Sky's the limit. Biggest problem, that's where the docs are paid. So if you have some serious health problems, that is going to be very painful financially for you. So that 20% is on you. And then lastly, we said that we had on the B side, if you went to a doctor that did not take assignment, but added to the bill, that additional amount they add is limited to 15%. We call that an excess charge. And whenever excess charges occur, who's responsible for those? You are. And so those are your gaps or your liabilities on the B of Medicare. We have our deductible of $203. We have our 20% coinsurance that never stops, and then the possibility of excess charges. So the majority of people who make the decision to stay in original Medicare A and B are usually not real comfortable with all that liability, that exposure. So what they do is they will buy supplemental plans. They'll take that liability and they'll transfer that away from themselves to an insurance company. And that's all we do when we buy insurance. We transfer liability. If I wreck my car, I don't want to have to pay for the repairs, especially if I cause the accident and hurt other cars, right? I'd be responsible for all that. So I don't like that liability. So I transfer that away to my auto insurance company and I pay them a premium to take that liability away from me. If my home burns down, I don't want to rebuild it. So I've taken the liability of that, the financial risk of that. I've transferred that to my homeowner's insurance company. I pay them a premium. So in original Medicare A and B, I just taught you the exposure, your financial liabilities. You can take all of those or most of those and you can transfer it away to an insurance company and you pay them a premium to take that liability from you. That is called a Medigap policy. So you pay them a premium, they issue that policy to you, agreeing that they will take the liability from you. All right. Now, in this whole system of Medicare supplemental plans, there's actually 10 different options. Now, I'm not going to tell you about all of them for the sake of time. I'll tell you about 3. But what's very important to know is that these plans are standardized by Medicare, which means what? Each of these letters represents a different coverage amount, a different policy amount, a different amount of liability that you transferred, and a different amount that you retained. All right. So we have these 10 different letters, all standardized by Medicare. Medicare sets the rules for what bills are paid and what bills are not paid. Now, the insurance companies make these plans available. You buy them from them, but Medicare sets the rules for what's going to be paid and not paid. So let's talk about the top 3 plans. Number 1 is the F plan. Now, the F plan's been around for years, and it is a plan that truly is full coverage. That covers all the gaps except for, it covers all the gaps that exist in original Medicare, A and B, covers everything. Now, the problem with the F plan today is this. There's some rules. They've been phasing the F plans out. So what happens if you're born before January 1st, 1955, you're born before that point in time, then you can still buy F plans. F plans are still an eligible purchase for you, okay, if you're born before, which simply means this. You started Medicare before 1/1/2020. You can buy F plans. There's millions of people who have F plans, and they're going to get to keep those plans. But anyone that's born after this, which is after January 1st, 55, you cannot buy F plans. So F plans are not an option for you, okay? They phased them out. There was just simply too much use with F plans that were high, really high coverage, and the government said, They want to eliminate them. So now we're in that process of eliminating the F plans. Okay, so instead of the F plan today, what has become the most popular plan is the G plan. Now you're going to notice the G plan is going to cover all the gaps except one, and that is the annual Part B deductible. Remember, in 2021, that is $203. That is once a year. So the first 203, if you have a G plan, is going to be paid out of your pocket from anything out of the B side of Medicare. Remember what that was? Everything outpatient and everything doctor related. So that first $203 in bills is going to end up as a bill in your mailbox. So that would be the first, let's say our first claim is an MRI. You'll pay the first 203 of the MRI. After that, we got 100% coverage. Let's say you have maybe 2 doctor visits with some lab work, whatever it takes to get to the 203 will be out of your pocket. And that's it. So that's the difference between the F and the G. Number one, the premium is lower on the G. And number two, on the G, you will be responsible for the 203. Now, the good news is in most of the regions around the country, we're going to see about a $40, at least a $40 premium difference. So if I buy the G, I just saved $40. If I bought the F, if I could because of my birthday, I just paid $40 extra dollars. So 40 times 12 would be $480. And what did I get out of it? $203 benefit. So I paid $480 for a $203 benefit. It's just not a good value. And that's why people that even were born before January 1st, 55 are not getting F plans, because they're not, they're really the best value. Okay? All right. So then there's one more plan that you'll hear talk about, and that's called the N plan. Again, a different letter, different coverage amount. And this covers all the gaps except the annual Part B deductible and excess charges. And you're responsible every time you went to a doctor or a therapist or anybody, you have a $20 copay to any doc, and then $50 to go to the emergency room. Now that's a pretty small, so that's not a big deal. But I am concerned about lifetime copays. And I'm also concerned about the possibility of excess. Right now, only 1 of 10 doctors will do this. But in 20, 25, 30 years, I have no idea. There could be 50% or 100% of all doctors adding to the bill. And so you're just taking on the risk. What are you going to say? Well, the difference in most markets right now between the G and the N is about $20 a month. So you'll save about $240. So you got to decide whether that $240 savings is worth the risk of taking on excess as well as copays, which could happen, really for the rest of your life. So those are the top 3 plans that are available in this market. Now, one thing that's very critical is this word right here, standardized by Medicare. And what that simply means is this, and let's use our G as our example since that's the most popular plan today. That G plan covers everything but the B deductible. And it doesn't matter, folks, whether you buy that G plan from ABC insurance company or XYZ insurance company, the coverage is all the same. So we would never say, let's go with this particular carrier so that we think they'll pay better than this other carrier. That's not true. If you buy the G plan from any carrier, the same bills are paid, the same type of bills, the same amount of bills are going to be paid. So we don't go with a carrier to get better coverage. Now, we may go with a different carrier to save premium dollars. They're certainly not going to be the same in their premiums. So some are lower, some are higher. They're certainly not going to have the same ratings and not the same rate stability. So there's a lot of other factors that would vary within these companies, but the coverage is always the same because Medicare has standardized each of those letters to determine what bills will be paid and what won't be paid. All right, so that's the way it works with Medicare supplemental plans. Now, this is very, very important to understand. Medicare covers well, very, very good, but there are a couple things Medicare doesn't cover. Notice they do not cover long-term custodial care. This is bathing and dressing and eating and toileting. We call these activities of daily living. A lot of people have a nursing home insurance or that type of insurance to cover that because Medicare does not. Routine dental care, extractions and fillings, Medicare doesn't cover that. Cosmetic surgery, acupuncture, hearing aids. So Medicare covers lots of things, but those things are not covered, which means what? It means that if Medicare doesn't pay these items, neither will your supplemental plan pay. And that's what we want you to understand. And remember that when you buy a supplemental plan, that supplemental plan is following Medicare. Medicare pays, it will pay. Medicare doesn't, it will not pay. Okay? And so that's how supplemental plans work. They're following Medicare, and they will pay if Medicare does. There's one exception to what I just shared with you, and that's this. Some of these plans will offer foreign travel emergency coverage. These 3 letters and a couple others simply means this. We've got a great illustration. We had a lady recently that went to Ireland on vacation, gets off the plane. Within 12 hours, she's in the hospital. $172,000 bill. She's in the hospital in Ireland 4.5 weeks. She had something happen with her liver, almost died. She did survive that, but it had a $172,000 bill. How much did Medicare pay in Ireland? And the answer is 0. Well, why? Medicare didn't cover it in Ireland. They cover it in the U.S. states, 50, and in the U.S. territories. But in Ireland, there was no coverage. So this is one and only one time when a plan will pay when Medicare did not. And what happens is these plans here, these letters, they attach $50,000 lifetime benefit, not recurring, but lifetime. And there's a $50,000 bucket that's attached there for if you're in a situation where you have emergency needs out of the country, those plans will pay up to $50,000. All right, so that's the way that works. So that's one exception to the rule these plans are following. Now, so this is also very important. During the very first 6 months of your Medicare Part B, you're going to be given a once-in-a-lifetime opportunity to buy any Medigap policy that's sold in your state, regardless of your health conditions. And what this means is during these 6 months, the insurance company cannot ask you any health questions whatsoever. Therefore, your acceptance is guaranteed during these 6 months. Now, that's a very lengthy statement, but it's also very important, which means when you go on Medicare, your A and B dates are going to be established. But that B date is critical because from that date forward, you have 6 months where the insurance company has to take you. That means they have to take all your pre-existing conditions. But do you suppose they have to take you after that 6 months? They do not. Then you have to go through underwriting to get a supplemental plan or to switch supplemental plans. So this period of time is very, very important for all people, but especially those that have some serious health problems. This could be your one and only opportunity to ever buy a Medigap policy. So let me explain those 6 months. What we're talking about is tied to the B date. The 6 months is not tied to whatever your A date is, but to the B date. So if my B date is January 1, 2021, here's my 6 months: January, February, March, April, May, June, which means what? July 1, 2021 on, if I ever want to buy a supplemental plan, a new one, or switch, I want to change letters, change companies. Now, from that point on, now I have to medically qualify. We have to ask you 25 health questions, check your medications, get a statement from your doctor, and then a whole process then could, if you can't get approved, you will not be able to get a Medigap policy, right? So many people think because Medicare has this open enrollment season every year that they can just switch and do whatever they would like to during that particular period of time. And that's not true. There's always rules for switching plans other than prescription drug plans, all right? But these have rules when you're going to switch supplemental plans. Now, supplemental plans can be kept for life. Very nice feature of them. And they can never be canceled, notice ever, by the insurance company unless you fail to pay the premium, which means when they write that supplemental plan G or N or F, whatever you buy, it's totally yours forever. Pay the premium. They can't cancel because of too many claims. They can't cancel because of your age. They can't cancel because you've moved. If you have a supplemental plan and you leave an area, you can take it with you. It's totally portable. And that plan can be taken really to any state. All right, so that's a very nice feature kept for life. So we tell this to our clients. When you think about your Medicare options, if you stay in original Medicare, your A and B is for life. Just pay your B premium. And your supplemental plan also can be for life. Again, just pay your premium. Can never be canceled, either one of those. Now, you have two options when you go on Medicare. And so I've spent a good deal of time now teaching about one of those options, staying in original Medicare A and B, probably get a supplemental plan to fill in the gaps, either fully or close to being full. And then you have a second option called Medicare Advantage plans. Now, these Advantage plans started in 2003 under the second George Bush administration. And so this is our second option when we go on Medicare. So I'm going to go into details for those of you that would want to opt for an Advantage plan. We'll make sure you understand really the differences. So what I'm going to do really for teaching purposes is this, to make it simple. I'm going to say to my right, I'm going to say this side represents original Medicare A and B, and I'm going to use a G plan as our example. And on this side, I'm going to say this represents Advantage plans. These are called C plans. They're called replacement plans. And when you go on Medicare, you have to decide which way you want to use your Medicare benefits, because you can't be on both. It's going to be one or the other. So let's compare the differences, all right? Now, there is one thing that both of these do have in common. There's one similarity, and that's this. If you're on an Advantage plan, you do have to be enrolled in Medicare A and B. Remember, A is free for most people. B costs $148.50 for most people, unless you're high income. But most people, you're going to have to pay $148.50 a month for that Medicare Part B. And so if I'm enrolled in an Advantage plan, I'm going to have to pay Medicare to be a part of the Medicare system, but I'm going to be insured by that Advantage plan. If I stay in this system, I'm in A and B, I have a supplemental plan. And again, to have the supplemental plan, I also have to be enrolled in Medicare B. So that's the one thing these two have in common. Either way, I've got to be enrolled in Medicare A and B, and I'm going to have to pay that B premium. But beyond that, these systems are totally different. Let's look at the differences. Number one, you'll have a network of doctors and specialists and hospitals different providers, and those are called HMOs or PPOs. And we describe the HMO and define it with a small box because you'll see there are less choices. There's less doctors, less specialists, less hospitals that are going to be in the HMO. Another difference between the two is referrals. Sometimes HMO plans will require you see your primary care doctor before you see a specialist. PPOs never require that. And so PPOs give us more options as far as more providers to choose from than HMOs, and a little bit easier to use because we don't have to have referrals. Another big difference would be out of network. If you're on an HMO plan, you can't go out of your network unless it's urgent care or emergency. Otherwise, you've got to stay in your network, right? If you go out, you pay for it fully. If you're on a PPO plan, you can go out of the network. That's why we have the dashed line. We can go out. Now, here's what happens. You'll have a max out of pocket in network, max out of pocket out of network. Max out of pocket is usually in the range of $5,000 a year. Out of network, it could be $7,000 to $10,000 a year, but at least you can go out if you would like to do that to see a certain provider. So that's the difference. So we have networks with Advantage plans. How about over here? Original Medicare, do we have networks? No, we didn't. We can go anywhere that takes Medicare, any hospital, any doctor that takes Medicare. That really is our only network is Medicare. All right, so that's the difference. Number two, these plans, Advantage plans, have low or no monthly premiums. As a matter of fact, in every market today, about 50% at least of all the plans available are going to have zero premium, meaning you don't have to pay anything to the insurance company to enroll in that Advantage plan. Now, we're still paying Medicare, but we don't have to pay that company. Well, why is that? Well, here's why. Because instead of paying a premium, what you're doing instead is you're paying co-pays for all your services other than preventive and maybe a doc visit, but everything else that you have in healthcare services on that Advantage plan. Could be a procedure, a surgery, specialist visit, maybe lab work or whatever, but all the services that you have are going to be charged some type of a copay. All right, so we pay copays instead of premiums. And the good news is those copays eventually will stop, of course. And this is the new range, and this varies depending upon HMOs and PPOs and what part of the country you're in. But on average, it's going to be between $3,900 to $10,000 maximum out of your pocket. So all your copays will eventually stop. Now, I will tell you the worst thing that can happen is if someone, I've had it happen before, we had someone diagnosed with cancer. We had a lady last year got diagnosed with cancer, breast cancer in September. And if you get treated for cancer, you always max out. Chemotherapy, radiation, surgery, it's all very expensive. So she maxed out. Her plan actually was $6,700 for the plan year, $6,700. So she gets diagnosed with cancer in September and maxes out very quickly, where cancer treatment wasn't over. So it brings into the next year. And what happened? These numbers reset every January. So again, within just a matter of a couple months, she maxed out again because of the expenses of the cancer treatment and all the follow-up. So she spent $13,400 really within a matter of about 5 months because she had this resetting of the annual max out of pocket. All right, so that's the way they work. So it's a copay-based plan. Now, I want you to give a kind of a feel for how these plans work. You're going to see doctor visits, usually zero today, upwards maybe to $10. You go see your specialist, your orthopedic doc, your cardiologist, maybe your endocrinologist or your OBGYN doc or something. You'll pay a $25 to $50 copay. Urgent care and emergency room is going to be between $40 to $120. And this is one place that we never worry about network here. We have no network here. You just simply go wherever you need to, and you'll only be responsible for your copay for that. And then we have tests, labs, x-rays, somewhere between $0 to $50 for those, depending on what the test is and where you get that. Now, the scans, these would be your MRIs, your PET scans, your CAT scans. We're going to be spending somewhere between $200 to $400 per scan as a copay for those services. Outpatient surgery, so this would be someone that goes in for maybe cataract surgery, maybe a knee replacement, maybe a hernia operation, gallbladder removal, something like that. Almost always outpatient today. And you would just pay a flat copay to that ambulatory surgical center that covers the doctor, the surgeon, the anesthesiologist, the nursing services, and the facility fees. Everything's included in that daily, that particular procedure amount, this particular copay. And then we also have hospital stays. Now, you recall that in original Medicare, we just had that flat $1,484 deductible. Well, some Advantage plans have deductibles, maybe $500 or $1,000. And so beyond the deductible, you have to pay. What happens with hospital stays on Advantage plans, you have a daily copay. And those daily copays vary throughout the country. But notice they always stop somewhere. Some plans stop after 5 days in the hospital. Some stop copays after 6, some are 9, some are 12. But the point is we always pay a daily copay for each hospitalization throughout the year. And these daily copays are being applied to our max out of pocket. And so if my daily copay is $300, that $300 is going to cover everything I receive in services in the hospital that day. It could be just standard care or critical care. It could be I could be having a surgery that day or not. The copay is still the same. So all the doctors, all the tests, everything that could be billed during that hospital stay for that day is covered by that daily copay as far as your responsibility. The Advantage plan will pay the rest after that. All right, so let's just do a quick example. Let's work through a comparison. Let's say I'm in the hospital for, let's say 5 days. Average right now is about 5.5. And my daily copay is $300. So I'm going to spend $1,500 in copays to the hospital. And that covers everything. Advantage plan pays the rest. And let's say a couple months later, I'm having some abdominal pain and they want to do a CAT scan or MRI or something. And let's call that test $300. Very common. So I'm going to have to pay $300 to that diagnostic imaging company. And then let's say a couple months later, I have cataract surgery. And let's say it's an outpatient procedures. It will be $275 for each eye. So that's $550. So I paid $1,500 in copays for my hospital stay. I paid $300 for my MRI. Now I'm at $1,800. And then I had $550 that I had to pay for my cataract surgery. So I just spent, what, $2,350 in copay. So I'm paying as I go for the services that I need. Now let's compare that if I had an original Medicare A and B with a supplemental plan G. And so the first thing I do is go to the hospital. What will it cost me to go to the hospital total? Well, my B deductible, right? $203. Everything else is going to be covered, whether I'm in 5 days or 10 days or whatever. It doesn't matter. That B deductible 203 is taking care of my out-of-pocket expense. And then I have an MRI a couple months later. What will that cost me? $0. Why? Because you've already met your deductible once a year. And then I have cataract surgery on both eyes. What will that cost me? Again, $0. What's happened? Well, it's $0 because I've satisfied my deductible and all the rest of the liability I've transferred to the insurance company. And now I pay them a premium, and now they're paying all my medical expenses other than the B deductible. So I pay a premium, pretty much done. Over here, pay copays as I get services throughout the year. And again, just two different systems, and you have to decide which you're going to be most comfortable with. Now, there are some other differences with Advantage plans. Number one, they do include a prescription drug plan. It's embedded. It's part of the package. We tell people all the time, be sure if you go on the Advantage plan, yes, we want to make sure docs are a network and hospitals a network. We want to make sure that we have good coverage for our prescriptions as well, because sometimes they're excellent. Other times they're kind of mediocre. So check your meds to make sure we got good pricing on that as well. Number two, these plans, Advantage plans, always include a benefit that's called silver sneakers or something similar to that. And that means on the Advantage plan, you can go to a certain gym and work out, and different facilities will take your silver sneakers benefit, and a lot of YMCAs and community centers and curves and just different places. These health fitness centers will allow you to come into their facility if you have that silver sneakers card, and then you can work out for free and be a part of the exercise programs there. When it comes to supplemental plans, most don't offer that. So that's kind of a perk that is offered by Advantage plans. And then another thing about Advantage plans, they're not written for life like a supplemental plan would be. They're written for 1 year at a time. That's it. 1 calendar year. And those plans have to be reviewed every year. Sometimes you can renew them. Other times, they sometimes will pull the plan, or doctors come and go from the plan. So that's why every year we have this annual enrollment period, which is from October 15th through December 7th. Okay, those are 7 weeks for people to be able to switch their Advantage plans if they need to. And sometimes that will happen for sure. But because they're only written for 1 year at a time, the plans have the right to change whatever they want to. And therefore, the consumer can also change their plan if it's in their best interest to do so. All right. And then fourthly here, Advantage plans do require pre-authorizations. Pre-authorization means that you're needing something that's kind of on the higher price side, which would be an MRI or maybe a CAT scan, certainly hospitalization, any kind of a surgery, a skilled nursing stay, anything that's going to be pricey, then that is going to have to be approved by the Advantage company. All right. And so now to see your doctor, you don't have to pre-authorization. To see specialists, you're not going to have to either. But most of the services, you may need a pre-authorization. They tell us now about 70% of all the services that are needed on Advantage plans have to be pre-approved. So the doctor says you need an MRI, the doctor says you need a hip replacement or knee replacement or something. That doctor's orders will not be completed until there's the company, the Advantage company has to approve that. So the nurses or whoever within the doctor's office will actually contact the company, and someone within that Advantage company is going to make a decision whether they're going to go ahead and pay for that. And sometimes they say yes, and sometimes they say no, we want you to go to therapy for a couple of weeks. We've had a couple of situations recently, actually, where there were 2 ladies that need hip replacements. And Both doctors said you need a hip replacement. One lady checked with her Advantage plan and they said, no, we want you to go to therapy for 9 months first and then check back with us and we'll look at that again. So no hip replacement. Okay, she had to go to therapy first. We had one lady who needed a full hip and the Advantage company said, no, we'll pay for a rod only, not a full hip replacement. And so again, that's what she had to do. Now, if those ladies had been in the original Medicare system where Medicare said, we will pay for that, and doctor said you need that, it would have been done. There would have been no pre-certification because in this system, that supplemental company has no say-so. It is your doctor of Medicare that make all decisions. Over here, if you have pre-authorizations, then that plan is going to have to approve those before you'll get those particular procedures done. Just a difference, okay? And then number 5 here, you must medically qualify to switch to a Medigap policy. Now notice, after your Advantage plan trial period expires, most people are given the opportunity to be on an Advantage plan, and during their first 12 months, they have a trial period. And that means during this 12 months, they're basically test driving or putting on for size the Advantage plan to see if they like it. And during those first 12 months, anytime, any reason, if they decide they don't like their Advantage plan, right, that's the trial period. Anytime, any reason, they can move from Advantage over to supplemental plan, and that company has to take them. But here's what happens. If I stay in my Advantage plan 12 months in one day, if I ever want to get off the Advantage plan and move over into this system, now I have to medically qualify to make that move, which means what? To move from here to here, do you have to be ready to run a marathon? No. But we are going to ask you 25 health questions. We're going to check your medications to see what you're taking, and we're going to get a statement from your doctor. And so an underwriter from over in the supplemental company is going to have to approve you to make that switch. And again, I share this because so many people think that because Medicare has open enrollment, they can just switch and move very freely, and there's no rules, folks. There's always rules for switching plans. So if you start with an Advantage plan, within that 12-month period, if you have not switched over in order to move, you're going to have to medically qualify. And there's things that will keep you from moving: spinal stenosis, rheumatoid arthritis, osteoporosis sometimes, insulin-dependent diabetics, they have a difficult time switching. If you had an AFib incident one time, you'll never switch. So there's certain things and certain medications that will keep you on these Advantage plans, and you can't switch to a supplemental plan. So again, that's why this is a very important decision when you go on Medicare, to make sure you're comfortable with that decision. So this is something that you have to be aware of. The trial period, it does exist. Okay, so those are some of the differences. Now, to be covered by an Advantage plan, you're going to have to be enrolled in Medicare A and B. We discussed that. And you've got to live in the plan service area, which is a metro area. If you leave your metro area, let's say you're in Denver, Colorado, and you decide to move to Phoenix, Arizona, certainly you're going to have to switch that plan. You've left one metro area to another metro area, and you're going to have to take that. You're going to have to get a new plan. Over here, if I have a supplemental plan, I take it with me from Denver to Phoenix. I can take that supplemental plan with me. Over here, you'll have to switch that. And then a Medicare Advantage plan is not a Medicare supplemental plan. So that's what I've tried to teach you, the differences in these. You cannot have both at the same time. So ultimately, that's your decision. Are you going to have an Advantage plan, or are you going to have a supplemental plan? And Advantage plans, of course, are offered by private health insurance companies. All right, so here is really a summary of what we've been taught so far. And this has to do with inpatient, outpatient. We can stay in original Medicare, get a supplemental plan, or we can go with an Advantage plan. Now, I just want to give you kind of some ballpark here, because a lot of people like to know some cost. And so we already know that the B cost is $148.50. Now, supplemental plans are going to vary throughout the country. But basically, here's what you can plan on. Let's just talk about a G plan. You can get a G plan in some markets for $100, on the high side, maybe $150 a month. And again, I'm just trying to give you a range so you can kind of see in your mind what these cost. Now, all supplemental plans are going to be based upon gender, tobacco status, your zip code, and that's what's going to determine. So age, gender, tobacco status, and your zip code, location, that determines your premium. So I'm just kind of giving you a range for G plans throughout the country. And then we have to have a drug plan. The drug plan, notice, is separate. Now, right now, in 2021, most markets have a drug plan that's as low as $7.20, and there's some that'll probably be $70. So we have many, many plans to choose from. But because I don't know your situation, I'm just going to tell you the national average right now is about $30 a month on a drug plan. So we have $148.50, let's call it $150, and we have a $100 G plan, so we're talking $250. So we're going to be in that $280 range, upwards to maybe $330, depending on what part of the country you're in. All right. So this is something that's going to have to fit your budget if this is something that is that you want to do. And for some of you, that's no problem. Others, that may be a little bit tight. And so that's why we have Advantage plans. And when we go in the Advantage plan, remember, only thing we have to do is pay Medicare, $148.50. So what we've eliminated would be this and that. And so because it's all included, but instead of paying premiums, what are we going to do now? We're going to pay our copays until we hit our max out of pocket. So that more of the pay-as-you-go system, we pay Medicare. So we've saved these premiums and we've just taken on the risk of paying the copays for whatever medical services that we need. But some of you, that's going to be a better fit for you. All right. So those are our two systems. So what I want to close out with today is I want to talk about drug plans. Now, I taught a lot about the differences between these two systems and how they work and the cost and how you pay for them. But as we talk about drug plans, whether it's included or embedded, or it's a separate drug plan, the structure and the function of drug plans are all the same. Okay, so that will be the same. There's no difference there. So let me explain how this works. Number one, every drug plan is going to have a network of pharmacies to choose from. Some will be preferred, which means better pricing. Some will be standard. So in one plan, a network, they may say our preferred pharmacy is CVS. And if you go to CVS, you get better pricing. Another one may say you can go to Walmart or go to Costco or go to Walgreens, but they'll identify a preferred pharmacy, better pricing, all the rest will be standard. And sometimes you can get better pricing for your preferred prescriptions. Formulary just simply means that's the meds that are covered by that plan. And there are some plans that are going to have a good formulary, meaning about 3,500 medications. A better is going to have about 5,000 meds. A best is going to have about 7,000. So when you see these price variables in drug plans, that's what you're looking at. A $7.30 plan is going to have a decent formulary, but it's not going to have near the broad formulary as like a $70 plan will be. And sometimes people need that just because of the amount of medications that they take. And so we tell people really don't worry about what you're going to take in 2 or 3 years because you can change formulary, you can change plans. And you make that switch every year, October 15th to December 7th, if it's necessary for you to do that. So we always say, live in the present. Whatever meds you're taking now, that's what we want to get covered. And then if meds change, you can do that every year during the open enrollment period. And this is one thing you can change with no rules. Drug plan, if it's in your zip code, you can have it. No health questions asked whatsoever. And then this is the last part I'm going to close with, and that is showing you, teaching you really how drug plans are structured. And this is something that's totally different from what you've had on a group plan or an individual plan. The structure and the function of drug plans are definitely different. So I'm going to explain how that works. And really, to get this concept, you have to realize that when we compare our group plans and individual plans with Medicare, our group plans always have fixed copays throughout the year. So we have a list of meds covered by our group plan. There's a tiering number that establishes what our copay is going to be. So I may have a tier 1 medication that costs me $5 a month, and I pay $5 on the group plan, whether I pick up the prescription in January or July or December, it's a fixed copay. If I have a tier 3 medication, it may be $50 copay. But again, it's a fixed copay throughout the whole year. January, July, December, I pay the same amount. We would call that system a one-stage system with fixed copays throughout the year. Medicare plans actually have 4 stages with fluctuating copays. So every drug plan that we would get could have the potential of having a medication that could change the price 4 different times throughout the year. So we have to understand the 4 stages and how it is that we move through the stages. So that's what I'm going to explain as I close out today's session. Number 1, our first stage is called the annual deductible. And the deductible is established by Medicare. Some plans lower that, some plans don't charge it, but most do. But all this simply means is you don't have to show up necessarily and write a check for $445. Let's say that you're taking a couple generic medications. Let's say you're on a medication that's $2 copay for your cholesterol, and you're taking a high blood pressure med that's $2, and that's all you're on. And so what do we have every month? We have $4 in copays. We multiply that times 12, and all year long, our medications cost us $48. And by the way, this is the story for about probably half of you viewing this today. So if my medications are $48, will I ever reach my deductible? And the answer is no, you won't. That 48 is applied to that, but you never reach it. And if we never reach our deductible, then we stay in this stage the whole year, January to December. And that's probably going to be good 50 to 70% of you. That will be your story. You'll never reach your deductible. Well, let's suppose that I'm on a medication that is called Eliquis, very expensive blood thinner, costs $500 a month. If you're on Eliquis, guarantee you're going to meet your deductible. You would have paid your deductible and you would have had a copay of probably $45 for Eliquis. And so that medication that would have cost you $490. Okay. And so what happens? We've met our deductible, we've paid our copay, And now we are done in stage 1. And if I ever meet that deductible, then I go to stage 2. And in stage 2, notice my copays are based upon the tiering of the medication, just like our group plan. So let's say I'm an Eliquis and I have a $45 copay. My first fill cost me $4.90 in January. But now in February and March and April, May, June, July, and August, I'm just simply paying my copay. And the insurance company that I got the plan from is paying the difference. They're paying that other, $455 from that coverage. And so you pay $45. But here's where the difference is. Every time you get a prescription picked up on Medicare plans, what's happening is behind the scenes, really in the computer system, Medicare is tracking the full retail costs. So they're tracking that $500 for Eliquis. You only paid $45 from February to August, but what's happening is they're tracking the full retail. And if that full retail cost ever reaches a total amount called the threshold, it's a dollar amount. And if we ever, through the full retail cost, reach the threshold, which this year is $4,130, that's the threshold. And the key to understand the threshold is that is retail. And folks, you didn't pay that. In fact, you only paid maybe 20%, 25% at most of that. The insurance company paid the rest, but Medicare is tracking retail. But if we ever get to that number, you are now done in stage 2 and you're going to stage 3, which is called the donut hole. Everyone's heard the donut hole. They're afraid of the donut hole, but they don't really understand it. And so now what I'm teaching you is that if we never hit that 4,130 in retail, then you'll never go to the donut hole. In fact, only about 5% of the Medicare population will do that. But let's go back to my Eliquis example. $500 a month retail for Eliquis. How many months does it take to reach that? About 8 months, all right? So by the time I'm getting into almost in September, now I've reached my threshold, and now I'm going to move on to my next stage, which is called the donut hole. And here in the donut hole, I have a different copay, and that copay is going to be 25% notice of the retail cost of medication. It's a flat copay. So if I have a $100 medication in the donut hole, it costs me $25. If I have a $500 retail medication, what's it going to cost me? $125. So now that same Eliquis medication that I first filled paid $4.90, and then the next 8 months I just paid $45 because now I'm in the donut hole. It's going to cost me $125. I'm in the third stage, and therefore I have my third copay. All right. And so what happens is 5% of the Medicare population will get here, and it certainly is painful for most people that do. And so now they track a whole other number. For the sake of time, and I'm going to get into it, but it's $65.50. And only 1% of the Medicare population will ever get to $65.50, but those who do then go to stage 4, which is called the catastrophic stage, stage 4. Now we have our fourth copay, and this is just 5% of the retail cost. So that's going to be, what, $25 for that Eliquis. So my first fill for Eliquis was $4.90 when I was in stage 1. Stage 2, I just paid $45, and I did that until I hit the donut hole, and my Eliquis went to $125, and now if I'm in the catastrophic on Eliquis, cost me $45. And those are 4 different stages, 4 different copays. And that's why I'm saying every drug plan has fluctuating copays depending upon the stage that you're in. Okay, very, very confusing system, but hopefully that sheds some light on this. And again, there is one way to avoid the donut hole. Just don't take any medication that's advertised on TV, and you probably will never end up in the donut hole. Okay, all right, so here's a summary with drug plans. Enrollment into drug plans are optional. Choosing to go without a drug plan is very risky. Sometimes people don't take any meds, so they assume I don't need a drug plan. Well, that can change. My home's never burned down, but I'm not going to go without homeowner's insurance, okay? And so you need a drug plan. It's just too risky. And if you go without, you'll result in lifetime late enrollment penalties, and those penalties really can add up. But the biggest risk is really if something happens to you during the year, you cannot pick up a drug plan mid-year, and if you need expensive medication, you will be full cost on the med. If you have a drug plan and you're on something expensive, you will pay a fraction of that cost. So that's why we're saying get a drug plan. All right, now drug plans are purchased from private health insurance companies, either standalone or they're embedded within the Advantage plan. And so either way you want to go, you're going to have to live with this particular system of 4 different stages and fluctuating copays. All right, and so the insurance industry knows that this is very confusing. And so as you make your decision to go on Medicare, you do have a couple different options to be able to get some help with the insurance plans and your Medicare enrollment. Number 1, you can use what we call a captive call center agent. And this is an agent that works for, notice, one company. And most call centers are captive. You call into their 800 number, and they're going to represent one particular carrier, one insurance company. And in most markets right now, we probably have 60, 70 plans to choose from. But when you work with a captive agent, what happens, you're looking at about maybe 10% of the market. But again, you're calling into a company that they're only going to promote their products, and their portfolio of products are going to be available. And so that's why we and others like us have chosen the other option that's available, and that is for you to use an independent broker. We are not captive to anyone. We're captive to our client. And so with independence, we look at all the options. So if there's 60 or 70 plans, we look at every single one of them so that you know everything available to you, and then we can pick out the best one instead of having to be captive to one particular company and their limited portfolio. And what I want you to realize, whether you go one or two, the cost to you is all the same. You can't save any money with one or two, or will you spend more money with one or two? Why is that? Well, because the companies set the premiums and the companies also pay the agents. All right. So there's no benefit to you as far as price between one or two. That would all be the same. Now, if you decide you'd like to work with us, it certainly would be our privilege to do so. Let me show you how we do business, and then we'll close out for today. Number one, if you do want to do business, you'll need to reach out to us. You can schedule an appointment. You can call the number or go online and schedule an appointment with one of our Medicare school guides. Okay. And one thing we're not going to do, we're not going to bug you. The majority of people in this business pester people and bug them. We don't do that at all. If you call us, we'll call you back. We're happy to have a conversation, but we are not going to pester you whatsoever. We've never done that, and we never will. Number two, if you do reach out to us and schedule an appointment, our team will do all the research necessary. We'll look at all the drug plans, the supplemental plans, the advantage plans, all the differences in all those, and we will do all the research for you. And what I want you to remember is that somebody has to do this, folks. If you let us do it, we're happy to do it for you. We do it all day long. If you do it on your own, you're going to have to figure it out. And it can be very confusing because there's so many different options, so many different opinions. But if you use us, then we certainly will do all the research. And then number three, we'll then do a review. Once we've done our proper research, then we'll look at every plan option available, and we'll compare those and lay those side by side and let you see the pros and the cons, the ins and the outs, and the different differences in these plans. We'll do all that with you during an appointment. And then once you've made a decision as to what's in your best interest, then we take care of all the red tape. I mean, everything. If you need help with an SSA.gov account, we'll guide you through the process. If we need to get you enrolled in Medicare, we'll take care of that as well. For you folks who are high income, we'll work through all the IRMA and IRMA appeals. For those of you who are going to work beyond 65, you're going to have to come in through the special enrollment period in that process. We take care of all that for you. Once you decide on all your insurance plans, we'll do all the enrollments, and we'll make sure that everything is done on time. We truly are full service A to Z. All right. So we'll do that. And then you have a relationship with an agent. Most call centers, you call in, you get a new agent every time you pick up the phone. Not so with us. You'll have an agent that's assigned to you, the one that guides you through that entire process. Okay. So that way you truly do have a relationship. And then the last question is, what does it cost to work with us, or frankly, anyone? It's totally free to you, because the agents cannot charge you money for planning of Medicare. The insurance companies have to pay the agent. So that's why it's always free to you. And so it wouldn't cost you anything to work with us whatsoever. We have a lot of people who are shocked by that because of all the service that we provide, but truly there's no cost at all to you. And if you'd like to schedule an appointment, you can call our 800 number here, or you can go online to medicareschool.com and you can schedule an appointment with one of our guides. I appreciate so much the opportunity to be able to assist you. And the next step would be to schedule an appointment, allow our company to continue to make sure that you are making the very best Medicare decisions for you. Thanks so much.